Welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. Women's Health CPD has always been a strength of MIMS Learning with over 100 learning modules on this topic. We've also been focusing this year on healthcare inequalities with, among other things, a module on the Embrace report on maternity care and a panel discussion on menopause, pelvic floor disorders and endometriosis. This topic of unmet needs in women, as well as in people who are assigned female at birth, got me thinking about sexual health. This is an area where greater awareness would really help women. I'm Sangeeta Krishnan, medical editor of MIMS Learning, and with me in the studio today I have my colleagues.
I'm Pat Anderson.
And I'm Dawn Liz Powell.
Did you know that 51% of women in the UK experience sexual health difficulties, but only 15% seek help? This is actually more than what's seen in men, where 42% of men reported having a sexual problem. But we'll discuss men's sexual health in subsequent episodes. So let's talk about sexual health in women.
Yes, I think it's a really important issue as sex is a part of life for many people, although of course not everyone. A study in The Lancet some years ago, for example, found that low sexual function was associated with depression and self-reported poor health status. And not surprisingly, low sexual function also had an adverse effect on relationships.
And what are some of the common sexual problems that are encountered in women?
Well, firstly, there are problems related to desire, hyperactive sexual desire disorder or aversions, for example. Second, there are orgasm disorders, difficulty in reaching orgasm despite adequate stimulation, which is called anorgasmia, or delays in orgasm. And last but not least, people can experience pain related to sex, such as dyspareunia, vaginismus, and vulvodynia. Within this podcast, I think we're going to discuss more about the pain and psychosexual consultation side, as this is where we have learning materials that could be helpful.
Yeah, and with sexual disorders, there are major psychological and emotional components. Psychosexual medicine is a branch of medicine that acknowledges that emotional or psychological issues can affect sexual function.
Yes, absolutely. And obviously sexual trauma would have a really major impact that's beyond the scope of this podcast. We have a module on sexual assault and forensic gynecology if you'd like to focus on this area as part of your professional development.
You mentioned this in the introduction, but can you just reiterate how common these sexual disorders are?
Yeah, they are pretty common and they affect 40% of the UK's population. According to the National Survey of Sexual Attitudes and Lifestyles, 51% of women from 16 to 74 years of age experienced one or more sexual difficulties. But get this, only 15% sought help for their problems.
I find that astounding because I wonder how it compares to other problems that affect 50% of women. You don't hear much about sexual difficulty. It's not really on the radar compared to other common conditions such as, say, for example, back pain or depression. And that 15% coming forward to seek help for their problems, that's really low. Maybe because women don't come forward, but perhaps also because healthcare professionals don't ask about this issue. I suspect it's a combination of both. And it's interesting, on our Health Inequalities webinar, which is free to access, by the way, that consultant urogynecologist Mr. Majid Abdelrahman said that women are very reluctant to talk about problems such as urinary incontinence or prolapse symptoms. I guess we're in the same general arena here of people feeling embarrassed to bring up the topic or ashamed of their problem. And I guess this is amplified when there's cultural baggage around the idea of women feeling empowered to demand a better personal experience than they're getting. And when Googling around this topic, I came across some interesting research that women were more likely to seek professional help for problems affecting vaginal intercourse within a heterosexual couple than they were for problems affecting their own personal experience. Fascinating stuff. And this raises the possibility that it's when the male partner has an issue because of the woman's problem, there's more likely to be a consultation resulting from that. So overall, I think there's a lot to unpack when it comes to a woman potentially coming to their GP to talk about a sexual difficulty.
The idea that a woman only reports sexual difficulties because her husband has an issue with it rather than because she does is really disturbing. That implies that she might not think it's a problem herself, but she's seeking help because her husband has said something. Or, alternatively, she is bothered by the problem, but is not seeking help because it's not an issue for her husband. But if she does present to the GP Lack of time and resources may present a challenge for the GP. A 10-minute consultation may not be enough time to go through everything, given it's a very sensitive issue that requires a thorough history. Another challenge is identifying that sexual health is the real issue. While some women might go to their GP to talk about their sexual dysfunction, others might go about something else, and then they sort of bring it up later on. So the GP would have to sort of tease that out of them. And just sort of going back to what you were saying there, Pat, about how it might be healthcare professionals feeling uncomfortable raising the issue of sexual dysfunction because maybe they're too embarrassed, or maybe simply they don't know how to approach the subject.
Absolutely. And in our module on psychosexual disorders in women by Miss Leila Frodsham and Miss Eleanor Sine, they say that an empathetic listening approach and using open questions when taking history will enable patients to discuss their problems during a healthcare consultation. Though clinicians might think that moving away from a structured proforma will take longer, in reality, consultations are often shorter and more satisfying for patients and practitioners when this approach is used.
Yeah, and history taking is also highlighted in our clinical review on vulval pain. And this module, written by Mr. Majid Abdelrahman, discusses taking a psychosexual history. And he says when doing so, it's important to include the following questions: whether the woman has any concerns about her sex life, whether sex is painful, whether it's enjoyable, and whether the woman feels the lower vaginal muscles tightening up during sexual intercourse. Before we get into discussing vulval pain in more detail, let's just touch on the differentials mentioned by Mr. Abdelrahman. He says a clinical examination would exclude vulval conditions that could have similar symptoms, like lichen sclerosis and seborrheic dermatitis. And these conditions could also cause vulval pain through excoriation, splitting of the vulval skin, and itching. Other conditions such as aphthous ulceration, erosive lichen planus, and herpes simplex infection should be considered. And then after excluding differentials, you're trying to find out whether your patient has one of two types of vulval pain, or vulvodynia, and these are provoked and unprovoked. So let's look at unprovoked vulval pain first. Unprovoked vulval pain usually occurs in the perimenopause or after menopause and is associated with a lot of psychological morbidity.
Vulvar pain must be very distressing for the patient. How do you differentiate between unprovoked and provoked?
So the diagnosis of unprovoked vulvodynia is based on clinical assessment after excluding vulvovaginal infections, inflammatory disorders, and other vulval conditions. And evaluation of medical, surgical, and previous treatments together with sexual history will assist in identifying the specific conditions that cause vulval pain. Visual analogue pain scales and pain diaries are useful in assessing the degree of pain. In the case of provoked vulvodynia, this is characterised by vestibular tenderness on light touch. It's often found in the context of superficial dyspareunia. It's documented to affect white European people between 20 and 40 years of age, and symptoms are exacerbated by intercourse, tampon insertion, and pain during gynecological examinations. Women with this condition will be prone to stress and anxiety and experience reduced sexual arousal and have negative sexual feelings. These cases need involvement from psychosexual specialists. Clinically speaking, apparently the vestibular tenderness can be demonstrated using a cotton bud. No further investigations would be necessary, as this itself points to a diagnosis.
And what are the treatment options for someone with vulvodynia?
So for women with unprovoked vulvodynia, it's apparently vital that the women should get reassurance about their condition and an explanation of what it is. Tricyclic antidepressants and neuroleptics for 3 to 6 months are the first-line treatment, and there are side effects, so adherence to the treatment may be a problem. Acupuncture has limited efficacy and is time-consuming, but surprisingly, patients have shown high levels of satisfaction with it.
Can you get acupuncture on the NHS?
Actually, I got acupuncture on the NHS for when I was pregnant and I had hyperemesis. It was a twin pregnancy and I was throwing up. I got referred for it and it really worked for me. Although, saying that, I don't know if it would be available for someone with vulvodynia.
That's interesting. According to the learning module, counselling has a big part to play in women with provoked vulvodynia. Psychosexual counselling offers basic sexual function assessment and provides education, information and support groups for individuals or couples. The patient is counselled, ideally alongside her partner, in improving physical non-coital sexual contact and overcoming pelvic floor muscle hypertrophy with sensate focused therapy. Unfortunately, though, there is a lack of good evidence regarding effective treatments for this condition. Treatments do include local anaesthetic gels to numb the affected areas, especially prior to intercourse, vaginal dilators for sensitive pelvic floor muscles, and biofeedback training of the pelvic floor. And finally, vestibulectomy, which is surgical removal of the hyperesthetic skin, may be considered in cases where all other measures have failed. Patients who respond to topical lidocaine prior to sex have a better outcome with vestibulectomy.
Sure, that's a very legitimate procedure, but it does sound very drastic, removing hypersensitive skin.
Absolutely, and I agree this sounds like a last resort procedure, and I'm sure all other avenues should be explored first.
Before we move on from history taking, I think it's worth reiterating the point that regardless of what the sexual dysfunction is or whatever the cause is, this is something that needs to be very sensitively discussed. The next step is examination. We did actually talk about examinations in women presenting with vulvar pain, but what are the general principles of examination in a woman with sexual dysfunction?
So the psychosexual disorders module talks about observing how the patient is before, during, and after the examination, if an examination is required, that is. For instance, how they respond to the prospect of the exam and how they prepare for it. The module also asks GPs to identify if they feel uncomfortable during the examination.
The module also suggests that clinicians start with an abdominal exam to exclude masses. While finding a mass is unlikely, this helps to build trust with the patient because you're not going straight in and examining something sensitive area. Though bear in mind that for some women, including those who have experienced sexual trauma, any sort of physical exam may be challenging for them. During examination for physical signs, asking patients to demonstrate the area of pain can be helpful and help minimise discomfort. Only perform a vaginal or speculum examination if indicated. If there is superficial discomfort and no other signs, then such examinations are unnecessary and may only cause pain.
Yeah, and what I really like about this module is that it suggests using the acronym LOFTI or LOFTI. This stands for listening, observing, feelings, thinking, and interpreting to guide the initial consultation. Listening would involve open questions in periods of silence, allowing the patient to divulge and elaborate. It also entails listening to their tone or language and what is said or not said. Observing is about observing behavioral patterns like frequent cancellations, mannerisms, urgency, and demeanor. And as a GP, be mindful of your feelings. If you feel pressurized or a sense of urgency during the consultation, this may be an example of transference of feelings. Being aware of feelings in the room and how you as a healthcare practitioner feel before and after the consultation are also important. Noting what sort of doctor you're being and the motivation for which the patient is presenting are part of thinking. And finally, interpreting is about assessing the overall picture and identifying whether the patient's behavior or attitude are a defense mechanism or a way to hide anxiety.
Right, so we have discussed history taking examinations. Let's have a look at associated symptoms and what they could indicate. Earlier, we briefly mentioned pain during sex or dyspareunia, and we do have a red flags module on this subject. It should be noted that pain during sex does affect all genders, but it is more commonly reported by women. So, red flags to be aware of in women presenting with pain during sex include dysmenorrhea, intermenstrual bleeding, and postcoital bleeding.
And as a general note, unintentional weight loss and fever are two other red flags to look out for in presentations of dyspareunia.
And what do some of the symptoms suggest about the cause?
If there's dermatological abnormalities or infective lesions, it could be something like herpes. If you do identify herpes, a swab should be used to take a sample to confirm. A pale vaginal mucosa might be suggestive of atrophy. If pelvic inflammatory disease is suspected, swabs for gonorrhea and chlamydia might be necessary. The red flags module also has lots of information on the different tests and investigations and what they might reveal. For example, an ultrasound can reveal fibroids, and a diagnostic laparoscopy might be relevant for suspected endometriosis. Bartholin cyst, cervicitis, endometriosis, and vaginismus are just some of the possible causes of pain during sex. The module has an extensive list of causes if you do want to review this topic further.
So, Dawn, you briefly alluded to chlamydia, which is one of the most common STIs in the UK. And it's recommended that sexually active women under 25 have a chlamydia test once a year if they're not using condoms with new or casual partners.
This sounds an obvious question, but are younger sexually active people more likely to get chlamydia?
Apparently so. This is one of the risk factors of being 15 to 24 years of age. Others include having multiple sexual partners and inconsistent or incorrect use of barrier contraception.
Yes, and the test is pretty straightforward now with nucleic acid amplification. So what are the clinical features of chlamydia, or can it be asymptomatic?
Apparently, asymptomatic infection is common, but if there are symptoms, these include dysuria, urethral discharge, rash, rectal pain or discharge, tenesmus, intermenstrual or postcoital bleeding, dyspareunia, lower abdominal or pelvic pain, and increased vaginal discharge. And there may also be fever. And bear in mind, in addition to antibiotic treatment, the patient's current and former partners within the previous 3 months need to be identified and treated epidemiologically, including screening and treatment at the first appointment. Patients should be advised to avoid sex for 7 days from the start of antibiotic therapy so that reinfection risk is minimised. Sexual abuse must be considered in those below 17 years of age.
Yeah, and the NICE guidelines on child abuse and neglect would be a useful resource in this situation. Finally, just to mention some of the other related learning we have on MIMS Learning. Sexual dysfunction may occur when there are hormonal imbalances, diabetes, and other disorders that interfere with sexual function. We have a module about sexual dysfunction in women with diabetes that we've discussed in a previous podcast. So menopausal changes, like the low estrogen levels that occur after menopause, can lead to vaginal atrophy, leading to discomfort during intercourse. We have learning on all of these topics on MIMS Learning. Thank you for discussing this topic with me, Dawn and Pat. So what have we learned today? Sexual health is a complex and often overlooked area, especially for women. So many of these sexual disorders have both physical and psychological components. It's vital that clinicians approach these conditions with empathy and openness. Only a small percentage of women with sexual problems seek help. This is clearly due to stigma, shame, and the challenge of addressing these sensitive issues in a healthcare setting. In vulvodynia, treatments range from medications to counseling and, in some situations, surgery. In chlamydia, which can go unnoticed without regular testing, treatment involves contact tracing and antibiotic therapy. Using thoughtful communication techniques like open-ended questions and a holistic understanding of the patient's experience, we can make these conversations a lot easier. Ultimately, I believe the clinician's goal would be to create a space where their patients feel comfortable discussing their sexual health without fear of judgment, so that proper care can be administered. Prioritizing empathetic listening will help increase the quality of care provided and ensure that cases are identified and treated at the right time. Thanks for joining us in this enlightening discussion. We've been the MIMS Learning editorial team, and this episode was produced by Till Owen. Join us next week for a new episode. See you next time.